Today's module is on the neurologic exam, and I will be focusing especially on the motor exam, but I will also discuss briefly the sensory and reflex exams. This is a very important part of how we approach diagnoses in order to get an accurate answer within the exam room. It's so important that I will separately look at the upper and lower extremities in terms of a detailed neurologic exam. Some of the broad things I want to emphasize here: what are the benefits of a good neurologic exam? Well, first of all, it's often not done well by a number of our peers, and if you just develop a good, rigorous system, you'll find that you'll pick up diagnoses so much more than you would have before. Secondly, it is important to really focus on being rigorous and systematic. Be complete early on with your first few thousand patients, and then later you can take some shortcuts based on your clinical understanding of the situation. In other words, experience will allow you to shortcut some of what you do rigorously, but that takes really quite a few patients to get there. You're also going to want to understand whether weakness that you encounter during the exam is from something neurologic, typically painless, or from a musculoskeletal problem. So for example, if a patient has pain with activation of the quadriceps and they've had a knee problem or knee surgery, that's probably not neurologic. It's probably due to the fact that when you activate the quadriceps, there's pain in the knee and they reflexively don't want to give full strength. Neurologic weakness, by contrast, is something that is painless to test on a patient, and that will help you with your differential diagnosis as you try to look for the source of weakness on physical exam. The basics for the motor exam: we're going to use a scheme that was developed after the Second World War, where we rate patients' strength from 0 to 5. And I'll talk about that more when we get in the exam room, 5 being the strong or normal strength, and 0 being no strength at all, paralysis. One thing I want to emphasize is that sometimes if you look, for example, at some physical therapy notes, they will rate a shoulder abductor as having only 3 out of 5 strength. That's actually grossly abnormal strength. It's consistent with an incomplete spinal cord injury, and it's probably overly rating the weakness. On the other hand, for example, a number of surgeons will often say there's normal strength, and in fact, it's not normal if you do a careful exam. So really you want to develop these skills that allow you to grade between 0, paralysis, and normal strength 5. And again, we'll talk about that more in the exam room. One thing I want to emphasize is 4 out of 5 it's not like getting a B on a test. 4 out of 5 strength is in fact real weakness. Most of my patients, when they have weakness, it is at the 4 out of 5 level. And that will help us very much in terms of understanding the patient's underlying diagnoses. Another thing I want to emphasize is we will often go from proximal to distal. So in the upper extremity, we'll work on the shoulders and then move out to the elbows, the wrists, and finally the fingers and the intrinsic muscles of the hand. And I would say that when you do the exam, you want to give yourself a mechanical advantage when you're trying to detect subtle weakness. The classic thing is testing tricep strength on a patient. If you have the patient's arm out like this and you try to bring them into flexion or have them activate their triceps, it's fairly easy for them to do that. If you have the elbow in flexion, they have a lot of difficulty doing that, and you have a more sensitive test. And finally, I want to say that you learn from your patients. I've developed over 30 years by examining thousands of patients ways of detecting subtle weakness on physical exam, and I've become better at what I do as a result. I'll just touch on the sensory and reflex exams. As you may know, sensory modalities include light touch, pinprick, vibration sense, joint position sense, and temperature sense. In clinical practice, such as mine, usually we're looking at light touch and pinprick. If we suspect a neurologic deficit, we will use pinprick. If we don't really suspect neurologic deficit, say a rotator cuff tendinitis, we'll typically just do light touch. If I really need to get more advanced, I will look at temperature and vibration sense, etc., and I can demonstrate that in the exam room. Finally, reflexes, I would say, they're really kind of overrated. By the time someone has reflex abnormalities, usually we know the diagnosis. And I'll talk about that more again when we get in the exam room. An important thing to understand here is that I'm not really talking about reflexes for upper motor neuron problems, such as stroke or spinal cord injury. Then I think reflexes are actually quite a bit more important. I'm really talking about peripheral nervous system problems such as radiculopathy or pinched nerve, sciatica, that sort of thing. And finally, I generally reserve mental status, cranial nerve, coordination testing for very specific circumstances. For example, in the TBI, traumatic brain injury patient, we will look at mental status testing. Or if we think there's a stroke or something like that, we might look at coordination testing. But generally, in my common practice of peripheral nervous system problems and musculoskeletal problems, I don't have to invoke coordination testing and that sort of thing. Okay, let's go to the exam room. And again, we will break this up into the upper body and the lower body. For the upper extremity neurologic motor exam, I'm going to explain first the scheme of going up to 5 from 0 of the different muscle grades. Okay? So we're going to demonstrate here with elbow flexion. This is 5 strength. Okay, I'm pulling the arm straight. The patient is resisting, and I can't break her strength. 4 out of 5 strength is I can barely overcome her strength. Okay? 3 out of 5 is a much more profound level of weakness. This is where the patient can barely bring the arm up without resistance, but against gravity. Usually you don't see this kind of weakness unless a patient has something like an incomplete spinal cord injury or a stroke. 2 out of 5 strength is they could not do it against gravity, but if you eliminate gravity, they can pull it in. Okay, again, these are profound neurologic levels of weakness. 1 out of 5 is there's just sort of a non-functional flicker in the muscle. Maybe you can palpate it, but it doesn't really allow the patient to move the arm through much range of motion. And 0 out of 5 is complete paralysis. And the key here is that 4 out of 5 is really abnormal. Most of my patients, when they have weakness, it's in that 4 out of 5 range. Rarely do I see 3 out of 5 strength. That's pretty profound weakness. And as I said in the introduction, sometimes the physical therapist, for example, will give patients 3 out of 5 strength. And I see the patient and, they don't have a spinal cord injury. They may not be very strong, but it's at least about a 4. On the other hand, there are other providers, for example, the surgical community, they tend to rate everything about a 5. No offense to my surgical colleagues. I know they're very talented in what they do. But it doesn't really help the physiatrist, such as myself, understand what is the level of the patient's strength. One thing I would say is that when you start doing this a fair amount, you might start doing half grades. You might say, well, this is a 4+. I can just barely overcome the patient's strength there. So you can do pluses and minuses. I'm going to go through the exam, going muscle by muscle. And typically I would do serratus anterior, hold the arm up. And that's often part of my shoulder exam, but I'll illustrate it here. Shoulder external rotation, push out. And that's one of the rotator cuff muscles, infraspinatus. I'll move to the model here if I could. On the model, this is infraspinatus. Okay? It externally rotates the shoulder. And serratus anterior, the first muscle, that was a muscle that abducts, pulls the shoulder blade away from the rib cage. I would then move on to deltoid, hold the arm up here, recognizing that early shoulder abduction, as I discussed in the rotator cuff module, is achieved by a different rotator cuff muscle, supraspinatus. So if I was really trying to focus on supraspinatus, I would do an early abduction strength test. But here, I'm just going to focus on a general neurologic exam, so I'll look at deltoid. And that's a C5-6 muscle. Then elbow flexion, which is mostly biceps, but a few other muscles, such as brachialis and coracobrachialis. Triceps. And a theme here is you want the patient's elbow a little bit flexed, because that's how you can overcome subtle triceps weakness when you're testing a patient, as compared to if the patient's arm is out like this, you really don't get a very sensitive test as an examiner. Move over to wrist extension, wrists up, mostly C6, C7. You're always testing both sides. Wrist flexion, and this is mostly C7, maybe some C8. Wrist flexion, by the way, at the medial epicondyle is the origin of the wrist flexors. Wrist extension is the lateral epicondyle, along with the finger extensors. The next I would do is the finger extensors. And notice again, I'm not testing here. I'm testing out here. Why? Because that makes it more difficult for the patient and gives me a more sensitive testing of weakness. And then finally, I'll move over to the intrinsic muscles. Abductor pollicis brevis. Pollicis, Latin word for thumb. Abduction, for the thumb, this is abduction. It's not this, that's extension. This is abduction. And then brevis, because the muscle belly is inside the hand, right? It's an intrinsic muscle, so it's a brevis. That's median innervated, affected with carpal tunnel syndrome, for example. And then finally, the interosseous muscles, innervated by the ulnar nerve. And sometimes if I'm not sure there's interosseous weakness, I'll just pit my muscle against theirs, push out, and we'll see if there's a subtle weakness there. Okay, so that's basically the overall upper extremity neurologic exam. You can be more specific. For example, if you're trying to tease out radiculopathy at C6 versus C7, C6 involves more like supination. Biceps is a big supinator for the body, so I have the patient hold their arm up like this. And if that's relatively weaker, I think more C5, C6 radiculopathy. If pronation is weak, I think more of a C7 radiculopathy. So these are just finer points you can make as you start to really hone your skills towards specific diagnoses. Sensory exam I'll just touch on. There are 5 sensory modalities, as I've mentioned. We usually use light touch if we don't think there's a neurologic problem. If we do suspect a neurologic problem, we'll use a safety pin, disposable safety pin, and we'll go through various dermatomes, such as C5, C6. You remember this from medical school because you can make a 6 with your hand. That's where C6 is. C7, C8, T1, the medial part of the humeral area. And you would test those specifically, always comparing 2 sides. Sensory exam turns out to be less useful in general than I think the motor exam, but it is important. For example, again, with cervical radiculopathy. And finally, reflexes. I'll demonstrate them here. And that's reflexes for biceps, triceps, and brachioradialis. Those are about a 2 on a scale of 0 to 3. Couple things about reflexes. You need a big hammer. Never trust a doctor with either a very legible signature or not a big reflex hammer. Okay? You have to have a big reflex hammer, otherwise the reflexes generally are not very useful. The other thing about reflexes, they're kind of a late finding. I don't find them as useful. We love doing them, but they don't really help as much in this setting. If you've had something like a stroke, MS, spinal cord injury, reflexes obviously become quite important. Okay, thank you.